Welcome everybody to a new day from our mega online course. On behalf of my colleagues and lecturers, we would like to welcome all the attendees. You're all welcome. Hoping we would give you our best. On behalf of the attendees, I would like to deeply thank our lecturers and our mediators of the course. Thank you for the effort. Thank you for everything. Today, we have 3 lectures, 3 very, very important lectures. We're starting now with the first lecture, Dr. Samir Alansary, Professor of Intensive Care, and his first lecture will be renal problems with some electrolyte imbalance. Welcome, Dr. Samir, and we would like you to start your lecture, please.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Huda. Thanks for all coordinators team. Welcome for our attendees and good luck, inshallah. I am going today to discuss some of the problems inside the ICU through discussing some cases, demonstrating or highlighting metabolic acidosis, alkalosis, and hypophosphatemia and hypercalcemia, which I think are more common problems we face in the ICU. The first case, a man with metabolic acidosis. A 52 years man with known alcohol abuse is brought to our ER as stewardess. He is vomited, complaining of vague abdominal pain. On exam, blood pressure normal, 115/70, temperature 37, on pulse 98, and his liver is palpable, and sodium is 140, potassium 4.5, chloride 99, bicarb low, very low, about 12, blood urea nitrogen 37, creatinine 1.7. There is some impairment in the renal function. Of course, anion gap, sodium minus the bicarb and chloride will give me a high anion gap metabolic acidosis, 29. Serum ketones 1.4. And I think it would be better to estimate the beta hydroxybutyric acid, not serum ketones, because it messes the main ketone in the body, which is the beta hydroxybutyric. Serum osmolarity 340, and this means there is a high osmolarity concentrations. There is an osmolar gap. If you look to the sodium, about 140, and so the measured osmolarity here about 290, but the measured one 340. And so there is an osmolar gap, high osmolar gap. Lactic acid is about 3, ABG at 7.24, if there is acidosis, metabolic acidosis. Carbon dioxide 24, and oxygen 99. Urine examination pH 5, there is some white blood cells, some RBCs, few granular cast, and calcium oxalate crystals. Really, this case demonstrates typical alcohol intoxication, especially the ethylene glycol toxicity. Why ethylene glycol toxicity? Because there is some granular casts, which is calcium oxalate crystals, are found in the urine. Also, there is an osmolar gap. Also, there is a high anion gap. And so, if you look and see in your patient high osmolar gap, high anion gap metabolic acidosis, calcium oxalate crystals, sink directly in alcohol intoxication. And in any acidotic patient, which there is no explanation, you have to sink in this alcohol intoxication. The best explanation of this metabolic acidosis, as I said, is ethylene glycol, not metabolic acidosis of renal failure, because renal failure here is not so advanced to give me this picture. Methanol intoxication, of course, gives me another signs and symptoms. Lactic acidosis, it is not so high, especially levulactic acid. Ethylene glycol intoxication, yes, it is ethylene glycol intoxication because the characteristic calcium oxalate are present. Most important causes of high anion gap, high osmolar gap acidosis is ethylene glycol, methanol, and propylene glycol, and etomidate. Ethylene glycol, this alcohol causes the osmolar gap, and by time will give you the metabolites of it, which is the acids, as glycolic acid here, uric acid, oxalic acid, and so it will give you high anion gap by time. Methanol will give you formic acid and lactic acid. Propylene glycol will give levulactic acid and dextrolactase. Don't forget also propylene glycol intoxication. It is very common, especially in ICU using high dose of lorazepam. Lorazepam, the solvent which is used for lorazepam is ethylene propylene glycol. And so if you find your patient becoming acidotic, suspect there is a propylene glycol toxicity from accumulation of levulactic acid. These alcohols we have to treat rapidly because the metabolites of these alcohols will be injurious to the CNS, will be injurious to the kidney, and so on. And for our patient, ethylene glycol, if not treated rapidly, will cause renal failure, of course, and causes some central nervous system problems. Ethylene glycol poisoning should be suspected in an intoxicated patient with an anion gap acidosis, hypocalcemia, urinary crystals, and non-toxic blood alcohol concentrations. Ethylene glycol is a solvent. Propylene glycol also is a solvent for many drugs, and so suspect alcohol intoxication in using some drugs. Ethylene glycol is a solvent found in products ranging from antifreeze fluids, de-icing solutions, carpet and fabric cleaners, all these containing ethylene glycol, and toxicity will occur if we consuming it too much. It contributes to patients with metabolic acidosis of unknown cause and subsequent renal failure. Toxicity results from the depressant effect of ethylene glycol on the central nervous system. Metabolic acidosis and renal failure are caused by conversion of ethylene glycol to noxious metabolites as glycolic acids and crystal precipitate in the kidney and so on. And so try rapidly to correct and treat ethylene glycol by treating acidemia. You can give sodium bicarb if it is severe. You can prevent further metabolism. You stop the alcohol dehydrogenase, either by ethanol, and isonic nowadays we're not using ethanol much, or fumipizole, and it is specific. But in using fumipizole, suspect you will use it for several days, 3, 4, 5 days to eradicate alcohol or ethylene glycol alcohol from the body. Also try to increase the conversion of glycolic acid to glycine by using pyridoxine and thiamine. If the renal function is good, you can maintain the renal function and use forced diuresis if the patient is euvolemic or hypervolemic. Use saline, mannitol, and so on. But if the patient exhibiting severe ethylene glycol toxicity and you are afraid from renal impairment and you have to, or there is CNS manifestation, you have to remove through hemodialysis or continue veno-venous hemodialysis. Remove the toxic metabolites with hemodialysis or peritoneal dialysis should be offered to most patients, certainly if neurological changes or renal failure or severe acidemia faced or found in your patient. Case number 2, dialysis patient with metabolic alkalosis. I'm going to discuss metabolic alkalosis through this case. A 44-year woman on peritoneal dialysis presents with lower GIT bleeding. She requires right hemicolectomy and removal of catheters and is placed on hemodialysis. Post-op, the course is complicated by ileus, breast, nasogastric drainage, 4 to 5 liters per day. On exam, she is euvolemic. She has minimal residual renal function. Labs potassium 4.5, bicarb 45, high bicarb level. pH 7.56, it is highly alkalotic, alkalemia, severe alkalemia. Carbon dioxide compensating and so rising to 54. This is a mistake, a routine mistake inside the ICU, which is aspiration of nasogastric drainage and discarding it. Please take care of this. I saw all patients in some ICU, all manifested or all complaining from metabolic alkalosis from this frequent aspiration. Gastric residual, we can leave the patient with gastric residual or feeding him with gastric residual more than 400 or 450, 500. Don't aspirate and discard the gastric juice. You will precipitate metabolic alkalosis in your patient because you will lose the HCl from the stomach. A dialysis patient with metabolic acidosis, which of the following would be the most appropriate therapeutic intervention? I have to give acetazolamide, normal saline, spironolactone, ammonium chloride, or continue venous hemofiltrations. Really, all these items could be optimum for the patient, but the patient here is complaining of renal failure, and so I can't use this acetazolamide diuretics. I can't use normal saline because the patient will be overvolemic. Spironolactone, you can use these items in patients exhibiting good renal function. And so the only solution here is either HCl, and it is not mentioned here, or continuous venous hemodiafiltrations. This is the only treatment modality to be taken. Metabolic alkalosis, what is the causes of generating causes of metabolic alkalosis? Loss of hydrogen ion as nasogastric suction, antacids, chloride using diarrhea, renal using loop diuretics or as Lasix precipitate metabolic alkalosis, thiazide diuretics also, mineralocorticoid excess, aldosterone, and so on, causing alkalosis, hypercalcemia, post-hypercapnia, all patients with hypercapnic patients exhibiting some sort of compensation through metabolic alkalosis, and they are alkalemic, especially when you correct them on ventilator and so on, they will suffer from severe metabolic alkalosis if you not consider this point. Hydrogen movement into cells in state of hypokalemia, refeeding, it is a common cause of metabolic alkalosis because chloride ion loss and potassium decrease. Retention of bicarb also as milk alkali treatment, metabolism of organic anions as massive transfusion, recovery from organic acidosis, contraction alkalosis because of chloride loss. Treatment of metabolic alkalosis, of course, we will give saline, especially in patients exhibiting low chloride concentration in urine, or hypochloremic patient. They are responder to saline infusion, plus potassium chloride to correct the hypokalemia, correct the chloride depletion, allow bicarb excretions in the common collecting fluid, correct volume contraction, because you will decrease the renal aldosterone secretions, which are the main precipitating factors in contracted volume alkalosis. Correct potassium depletion, acetazolamide, spironolactone, amyloride, 0.1 HCl, or dialysis in severe cases, and also continue venous hemodialysis or continue venous hemodialysis filtration. This is a simple diagram for showing you how to diagnose metabolic alkalosis or metabolic pH abnormalities. Calculate the anion gap for any patients you have, sodium minus bicarbonate chloride, and so if it is normal, it is less than 12 millimole, this is a normal anion gap. If bicarb is less than 22, this is a non-anion gap metabolic acidosis, pure non-anion gap. If it is bicarb from 22 to 28 millimole, this is a normal anion gap. If the bicarb is more than 28 millimole, this is a metabolic alkalosis. But there is another type of alkalosis which is missed or concealed metabolic alkalosis, which is associated in some patients with metabolic acidosis. Suppose the anion gap is more than 12, this is elevation of anion gap, and so start to calculate the delta gap. If the delta gap, estimate the delta gap in both the anion gap and the bicarb. If the delta gap of the anion gap is more than the delta gap of bicarb, you have a missed or concealed metabolic alkalosis associated with metabolic acidosis. And I think I demonstrate this item in ABG lecture. If serum bicarb is elevated more than 28 nanomole, this is alone revealed metabolic alkalosis. If the anion gap is elevated, but the reduced in bicarb, The reduction in bicarb must equal the increase in the anion gap. I mean the increase in anion gap or the delta anion gap must equal the delta bicarb. If the delta anion gap is more than the delta bicarb, this meaning there is a missed metabolic or concealed metabolic alkalosis associated with metabolic acidosis. In all patients with respiratory failure, hypercapnic respiratory failure, as you know, severe COPD, obesity, hypoventilation, chronic respiratory muscle weakness, all those patients exhibiting hypercapnia and associated metabolic alkalosis for compensation. We have two types of patients. We have chloride depletion metabolic alkalosis, and those patients will respond to saline infusion for management, as in cases of vomiting, nasogastric suction, chloride wasting, diarrhea, remote diuresis, high dose penicillin therapy, renal hypoperfusion, which promote renin aldosterone mechanism secreted, activated, TBN with excess acetate, citrate, massive transfusion, plasmapheresis, bicarb administration, or milk alkali syndrome, and calcium and bicarbonate intake. All these are responder to saline, and they are responder to chloride, because there is chloride depletion, and I know the chloride depletion from the urinary estimation of chloride ion. If it is less than 10 to 30 mils, they are responding to chloride. The other type of metabolic alkalosis, non-chloride depletion metabolic alkalosis, saline unresponsive, and because the urine chloride is more than 30, and these patients, as in cases of active diuresis, patient with hypomagnesemia, so severe hypocalcemia, hyperaldosteronism, primary aldosteronism, as aldosterone secreting adenoma, bilateral adrenal hyperplasia, secondary aldosteronism also, renal secretion, tumor, malignant hypertension, renal artery stenosis, Cushing syndrome, exogenous mineralocorticoid, all these precipitate non-responders metabolic alkalosis. TBN with excess acetate, and citrate with massive transfusion and plasmapheresis, bicarb administration. All these may be not responding to saline and they need another management. If the patient hypervolemic, you can start diuretic, which promote bicarb excretion, especially by acetazolamide. You can give the dose of acetazolamide 1,000 milligram IV every 12 hours. If the patient is receiving another loop diuretics, if not receiving another loop diuretics, you can give only 500 milligram IV acetazolamide every 12 hours. But take care, acetazolamide causing hypocalcemia, and so you have to correct the hypocalcemia. Spironolactone aldosterone antagonist, and it is very specific here. Increased mineralocorticoid activity is one of the main causes of metabolic alkalosis, and so spironolactone may be useful for patients with volume overload or hyperaldosteronism. But it takes time to give me an effect, about 24 hours, 48 hours. Amiloride really is additional, it gives me additional benefit. It is preserve potassium and can potentiate the action of other diuretics. Also, at the same time, you have to hold or decrease the dose of alkalosis inducing diuretics as furosemide or Lasix. In patients with mild alkalosis plus severe volume overload, it may be possible to continue diuresis using combination of low dose furosemide plus diuretics, which promote bicarbonate as bicarbonate loss as acetazolamide and spironolactone. Dialysis really as a sole indication or potential treatment for metabolic alkalosis among patients with renal failure, it will be indicated in associated condition, not metabolic alkalosis only, except if the alkalosis is severe and there is some sort associated with it as electrolyte abnormalities and so on. And this one patient, this is one case exhibiting extreme alkalemia, pH 7.65, may contribute to an array of complications, including refractory arrhythmia, one of the indications for starting dialysis, or put it on ECMO and the patient responding just we correct the metabolic acidosis. And so we shifted to dialysis or ECMO for this or the extracorporeal renal replacement if the patient exhibiting severe CNS manifestations or severe cardiac arrhythmia. Hydrochloric acid actually is we can use it as an indication for IV hydrochloric acid severe metabolic alkalosis over pH over 7.55, and the bicarb is more than 38 millimole plus 1 over the following. If the other conservative modalities are not effective and the alkalosis is so profound that immediate control is needed, and some sort of arrhythmia, some sort of CNS depression, and you can't use dialysis, you can use HCl. And actually there is a protocol for using HCl, and you have to infuse it through a central venous catheter, and be sure is a central venous catheter in its side through X-ray film. Also, estimate the doses of the acid required shot for the desired bicarb. Keep the target 35 to avoid iatrogenic inducing metabolic acidosis in your patient. And this is the equation for calculation of bicarb excess. 0.5 times the lean body weight times the plasma bicarb minus 35 milli equivalent per liter. We use this high bicarb level to avoid inducing metabolic acidosis in our patient. Calculate the bicarb excess, and we have 0.1 normal, we have 0.1 solutions which contain 100 milli equivalent per liter, and 0.2 containing 200 milli equivalent per liter. The maximum safe infusion rate actually is 0.2 milli equivalent per hour. We can use in the average about 200, 300 milli equivalent for correcting the metabolic alkalosis. In practice, the average infusion rate is about 10 milli equivalent per hour for 0.1 solution. This is equal to 100 ml per hour. For 0.2, the equal 50 ml per hour infusion. Of course, during HCl management of metabolic alkalosis, you have to monitor the electrolytes, including calcium, magnesium, phosphate, ABG, VBG, after every 75 milli equivalent administration of HCl. A risk, of course, if it is extravasate, will cause necrosis of tissue and will cause volume overload, but we have to use it in certain situations, as I said, in severe arrhythmia or in some sort of CNS problems. The next patient we will discuss a man with hypercalcemia, 62-year-old man with hypertension and reflux GERD is admitted with hypercalcemia. His wife reports that he had an increasing abdominal pain, discomfort, constipation, and episodic bizarre behavior for 2 weeks. He also had a dry cough and unmeasured weight loss for months. Medications include amlodipine, omeprazole, calcium carbonate as needed for his heartburn. On exam, he was conscious and mildly volume depleted. Serum calcium very high, 24.7 milligram percent. Phosphate 3.8 milligram percent. Creatinine is about 1.7. Normal CBC, liver function test normal, EKG normal, chest X-ray normal. Immediate supportive treatment with fluid, calcitonin, and zoledronic acid was started. We discuss now a case of hypercalcemia and how to manage. At this point, which of the following would you order to evaluate hypercalcemia? You have to order to ask for parathyroid hormone related protein peptides estimation, or CT of the neck, chest, abdomen, and pelvis, or serum protein electrophoresis and radio and screening bone survey, or serum 125 dihydroxyvitamin D, or thyroid function test. I think all of us will think this patient exhibiting a hypercalcemia. Hypercalcemia in any patients get me in trouble. This patient may may manifest some sort of malignancy. And so I have to make survey for these patients and check the chest, neck, abdomen, and the pelvis, and make CT to explore any problem or any underlying malignancy. But I think it is very simple to order first a parathyroid hormone estimation and the parathyroid hormone related peptides and see if it is normal or if it is high. Serum protein electrophoresis and bone survey, I think these patients have normal CBC. And so the thinking in multiple myeloma and so on, not present. Serum 125 dihydroxyvitamin D, yes, it can increase calcium, but not to this extent. Thyroid function test, of course, is hyperthyroidism, increase calcium level, but not so high to this extent, not increasing so high. The causes of hypercalcemia in general, primary hyperparathyroidism, ectopic parathyroid hormone secretions, hypercalcemia of malignancy, and this is very important really. Local or disseminated bone involvement, humoral parathyroid hormone related protein associated in 80% of them, vitamin D associated, multiple myeloma, granulomatous disease like sarcoid. But in this patient, he exhibiting normal chest X-ray and I think no sign. Vitamin D intoxication, some malignancy like lymphoma, vitamin D 125 dihydroxyvitamin D. All this can cause hypercalcemia. Thiazide diuretics also, or milk alkali syndrome, and we don't forget this patient taking some calcium carbonate. He is suffering from reflux, and I think he is suffering from heartburn, and so maybe milk alkali syndrome. Maybe recovery from rhabdomyolysis or immobilization in ICU, common to see hypercalcemia in our patient due to immobilization, or familial hypocalcemic hypercalcemia. You find low calcium in urine and high serum calcium. Categories of severity of hypercalcemia must be oriented. Mild increase, less than 12 mg%, most go untreated. Moderate from 12 to 14 mg%, treat aggressively and symptomatic. Severe, more than 14 mg%, always treat aggressive regardless of these symptoms. Use ionized measurement whenever possible. Adjust total calcium for albumin level. If albumin is less than 4, we have to add 0.8 mg per deciliter for every gram deciliter albumin below 4 gram. For every gram less than 4, add 0.8 mg to every 100 cc of blood or serum. Treatment of hypercalcemia, this is a summary for treatment of hypercalcemia. You can give hydration first, pushing out calcium out, increase renal excretion. Loop diuretics only after volume expansion, not in contracted volume patients, otherwise you will precipitate renal failure. Glycocorticoids decrease the vitamin D level. Calcitonin effect actually is rapid and inhibit osteoclastic function and increase renal calcium excretion. It is a fast action. Biphosphonate take time to act as bamidronate or dimidronate and zolidronate, and it acts through rankle osteoblastic activity. Denosumab, monoclonal antibody binding to rankle and block osteoblastic activity. Hemodialysis effective only when the source removed. Withholding anti-hypercalcemic therapy may result in life-threatening emergency such as coma and death. And take care from hypercalcemia in your patient in ICU. I think this patient, all the investigations, parathyroid hormone within normal level, and even also the related protein, parathyroid related protein undetectable. And the chest, abdomen, and the pelvis was normal, bone survey normal, also vitamin D level within limits, and the 24 hours urine calcium was 385, which is within normal. What is the most likely etiology of this hypercalcemia? It is humoral hypercalcemia of malignancy, pseudohypercalcemia, sarcoidosis, familial hypercalcemia or milk alkali syndrome. I think, as I said, it is milk alkali syndrome, patient suffering from reflux, and they take calcium carbonate as a treatment of this acid state. Milk alkali syndrome, this is the most common cause of hypercalcemia in hospitalized patients. High dietary calcium plus alkali source with calcium carbonate overuse, high calcium normal or high phosphate metabolic alkalosis can make kidney injury, nephrotoxic. Parathyroid hormone and 125 vitamin D typically suppressed. Management is supportive, saline, removal of the alkali source, and be careful with diuretic if your patient is volume depleted. The last case is an elderly patient, man with respiratory failure and hypophosphatemia, 74-year-old man with diabetes, coronary disease, COPD, and chronic carbon dioxide retention, admitted in acute hypoxemic state and hypercapnic respiratory failure due to pneumonia. He is treated with beptazo and vancomycin, azithromycin, insulin, and desabrinazolone, ipratropium, and bitrol. His lab test immediately prior to intubation and 18 hours later are shown below. Before pre-intubation, the patient is highly pH is 7.07. After treatment, becoming more corrected, becoming 7.3. By carbon dioxide dropped from 85 to 52. Bicarb also dropped from 32 to 29. Glucose dropped from 185 to 160. Phosphate dropped from 4.5 to 1.2. This is suffering from severe hypophosphatemia. Fractional excretions of his phosphate was 3.5%. This an elderly man with respiratory failure and hypophosphatemia. What is the best explanation for his hypophosphatemia, which happened after correction of his hypercalcemia, after putting on ventilator? If it is glucosuria, or correction of respiratory acidosis, or rhabdomyolysis, or methylprednisolone, or acute hypoparathyroidism. Actually, glucosuria will cause drop in phosphate level, but if we look here to the fractional excretion of sodium, it is low, 3.5. And so it is not associated with glucosuria. Always osmotic diuresis causes high fractional excretion of phosphate. The second point, correction of respiratory acidosis, I think so. Correction is common in cases of hypercapnic respiratory failure, and we correct the hypercapnia, you will find your patient suffering from hypophosphatemia after correction. Rhabdomyolysis, it will increase the phosphate level, not decreasing the phosphate level. Hypophosphatemia causes rhabdomyolysis in the reverse, but rhabdomyolysis causes hyperphosphatemia, not hypophosphatemia. Methylprednisolone not increasing, so not decreasing phosphate level as this. Acute hypoparathyroidism reverse, it will cause hyperphosphatemia. And so I think the correct answer here is the correction of respiratory acidosis. Causes of hypophosphatemia in ICU, transcellular shift, very important, increased insulin secretion, acute respiratory alkalosis or correction of acidosis, refeeding, common cause of hypophosphatemia, hypokalemia, and so on. And I think most of us saw these complications after restarting feeding in a malnourished patient. You faced with a severe arrhythmia and even arrest if you not correct the phosphate and potassium level. And so start feeding gradually, always start feeding even after oral replacement of feeding, not only in TPN patients, in TPN refeeding. Hungry bone and post-parathyroidectomy, sepsis, all these causes hypophosphatemia with fractional excretion of phosphate less than 5%. Decreased intracellular absorptions also, excessive phosphate binders like calcium, aluminum, magnesium, and calcitriol deficiency also causes hypophosphatemia. Increased renal excretions as in case of hyperparathyroidism, Fanconi syndrome in renal tubular acidosis associated with phosphate depletion, this syndrome we know. Osmotic diuretics and solute diuresis causes hypophosphatemia, like in patient suffering from DKA, but the fractional excretion of phosphate here, as I said, more than 5% because of osmotic diuresis. Causes of severe hypophosphatemia: alcohol withdrawal, this is a very common, refeeding, DKA, TPN refeeding, acute respiratory alkalosis, correction of chronic respiratory alkalosis, and recovery and the diuretic phase of severe burns. All these causes of severe hypophosphatemia. Hypophosphatemia is one of the causes which can cause muscle weakness and difficulty in weaning the patient from ventilator. It can cause cardiac arrhythmia, severe cardiac arrhythmia, and causes decrease or depress the myocardial contractility. And so try to treat it promptly by phosphate replacement. Thanks for you and good luck, inshallah.
Thank you, Dr. Samir, very much for this informative, this simplification of such a hard and frequently met abnormalities in ITU and electrolyte imbalance. I think we don't have any questions for Dr. Samir up to the moment, I think, because you made it so clear that I think it's so clear we don't need clarification. Thank you very much, Dr. Samir, and we're hoping to see you every week with new pearl of your knowledge. Thank you very much, Dr. Samir.
Thank you.
Thank you very much.